But let's go ahead. I want to introduce you to Paige Farrell. Paige serves as the state lead for Healthy Families Georgia Network, which is part of Georgia's home visiting program. She is the program model point of contact for Prevent Child Abuse America and Healthy Families America program. And with that role, she helps provide statewide technical assistance, make sure formal quality assurance is in place, and of course, training to those that have programs here in Georgia. Also in this role, she works very closely with community-based organizations and helping with implementation around the concept of universal parent support and evidence-based home visiting services. She's been in this role for the past 11 years, comes with a wealth of information, and so glad that she's joining us today. I'm going to hand it over to you, Paige, and get myself muted and off camera, and we hope you all will enjoy today's webinar. Thank you.
Thank you, Jennifer, and good afternoon and welcome to the webinar. As Jennifer stated, my name is Paige Ferrell and I do serve as the Healthy Families Georgia State Lead through the Center for Family Research at the University of Georgia. I've had the privilege to be part of the Georgia Home Visitation Program for almost 20 years now and started in this current role in 2011. Previous to my work in this role, I was I managed the Healthy Families Program in North Georgia. And at this time, I'd just like for each one of the presenters just to go around and introduce themselves. So I'll pass it to Diana.
Thank you, Paige. Hello, I'm Diana Sanchez. I am the Site Development Specialist at Healthy Families America National Office. Prior to my role with the National Office, I too was a program manager at a local Healthy Families America site in rural Northern California. I had 2 sites and was expanding into a 3rd site when I joined the National Office and became part of the national team. So I have a total of 10 years with direct service, supervision, as well as program management of my HFA sites, and then almost a year with the National Office. I will pass it on to Lori.
Hi guys, my name is Lori Hatton. I am down on the coast, coastal Georgia. I'm the regional program director here for a nonprofit called Coastal Coalition for Children. I have been with Healthy Families 10 years this year, actually. And we have 2 sites. We have one site here in Brunswick, and the other site is based in Chatham County. And through that, we serve 7 counties, but divided between those 2 sites. So I'm really excited to be here with you guys. And I will pass it to Caroline, sorry.
Thanks, Lori. I was just going to pick up and run with it. Hi, I'm Caroline Pence. I'm the Director of Programs at the Family Support Council up in Dalton, the northwest corner of the state. I've been with the Family Support Council about 24 years or so. I've been in my current role for about 2 years, and prior to that, I was the program manager for our agency's Healthy Families program for about 22 years. Our program in Dalton serves Whitfield and Murray counties. So we're just thrilled to be with you here today. And we have an additional co-worker, Jennifer Henderson, who's under the weather today. So she's here cheering us on, and we hope that she feels better very soon.
Thanks, Caroline. So before we get started, excuse me, we want to hear from you. So I'm going to pull up a poll and invite you to participate. Just to give you just a little bit of time.
And we should have tested the poll because it's saying I'm logged in from another device, which I'm not, and it's inactive. So we'll come back to that if that's okay with you.
Yes, that is perfectly fine. That is perfectly fine. So I'll go ahead and end this. and we can move to the next. One thing I just want to make sure is that I want to encourage you to drop your questions in the chat box. And as Jennifer was stating, we will give time at the end of the webinar to answer additional questions. So feel free to do that. We really encourage your participation through this webinar. So let's get started. I will pass it over to Diana.
Thank you, Paige. So who is HFA? Healthy Families America is a signature program of Prevent Child Abuse America. The purpose of HFA is to support new parents beginning when pregnant or at the time their babies are born. For families facing great challenges, home visiting services are offered until the child is at the age of 3 or up to 5 when funder approved. The HFA model is based upon 12 research-based critical elements and is committed to demonstrating consistent service implementation and quality. Healthy Families America is a voluntary home visiting program model that is family-centered, culturally sensitive, strength-based, and proven effective in promoting healthy child development and preventing child abuse and neglect. Next slide, please. It is a big year for us at Healthy Families America. HFA turns 30 this year, and our parent organization, Prevent Child Abuse America, turns 50. What an amazing milestone. Starting with just 25 sites in 1992, Healthy Families America has grown into a network of more than 580 sites. So we're located in 38 states, Washington, D.C., 5 U.S. territories, and Israel. We're growing more each day, and we hope that we include sites from Georgia as well in that growth. Each year, HFA staff and sites across our network complete more than 1 million home visits and serve more than 73,000 families across our network. So how does this all work? How do we have such great outcomes? The HFA model is rooted in 3 core concepts: relational health attachment, trauma-informed practice, and reflective capacity. Relational health and attachment is our focus. Change happens most effectively in relationships with one another. We change because we learn from someone who cares about us. We change when people who care about us point out things that we haven't seen before. Most of the families in HFA didn't have a nurturing, relationally healthy childhood themselves. So oftentimes just having someone that they can trust is a new experience for them. This trusting relationship families build with home visitors is the catalyst for transformation. As we say in HFA, it's all about the relationships. Trauma-informed practice is a must-have in working with families. We would consider that to be the most high risk. In the HFA model, the realities of how trauma impacts our bodies and our brains is intertwined into our approach in engaging families, retaining families in service, and how we train our home visitors prior to their work with families. Reflective capacity is key because this is hard work. Let's be honest, this is really hard work. Vicarious or secondhand trauma impacts our staff. So we support them with high quality, frequent supervision that allows them to reflect on their feelings and experiences, the impact of the work. Home visitors have weekly supervision for at least an hour and a half up to 2 hours. And this time allows a supervisor to cover these key elements of the HFA advantage with the goal of supporting staff, thus improving staff retention and the support that's provided to families. We know when we have staff turnover, it impacts not only budgets, but it impacts family retention. So we want to keep our staff healthy. And this is where utilizing the effective supervision, reflective supervision is key to that. The HFA advantage can work in almost any context. Healthy Families America has a continuum of services which allows HFA sites flexibility to extend the reach of the model to a variety of families in utilizing specific protocols. Traditional HFA services enrolls families prenatally or up to 3 months worth of baby, and services are offered for a minimum of 3 years or up to 5 years when funder approved. This is what we consider that long-term support. Hfa Accelerated Protocols employs a shortened length of service for families with less risk, who can see outcomes more readily, progress through the program a lot quicker. These families may not need 3 years of service like our traditional HFA families. We also have the child welfare protocols. It takes the same HFA approach and works with families who have high levels of risk. The Hfa model for many years has worked with families connected to the child welfare, and these protocols fully utilize our core competencies of relational health, trauma-informed practice, and reflective capacity to concentrate efforts on families who could especially benefit from services, but oftentimes are left out. A site utilizing the child welfare protocols receives all of their program referrals from their local child welfare office, and families can be enrolled before the baby is 24 months of age. All parents can benefit from the support during pregnancy and throughout early childhood. Through the full continuum of services, communities can offer services to meet the needs of all parents, from those who are just needing short-term services to those with more complex needs. HFA offers services intensely with well thought out, defined criteria for the frequency of visits. The first several months of involvement with a family are critical for many reasons: building a trusting partnership with parents, helping develop a strong parent-infant relationship, supporting infant care and safety, assisting with the adjustment to parenthood, and addressing immediate concerns. And because of all these factors, families are offered weekly visits at the onset of services, and it decreases over time, as seen here on our HFA levels of service. Sites utilize HFA's level change process to determine the frequency of home visits consistent with the progress that's made by each family. It is unique and individualized to each family member. Typically, visits happen in the home, lasting about an hour. However, in our current times, virtual visits are conducted for the safety of all. I believe Lori will be sharing more information about home visits later on in the presentation. So how do we make this all work? Our active ingredients are the key to ensuring successful implementation of your HFA site. The HFA best practice standards are rooted in research. We look at what the research tells us, the outcomes provided by our network, and are constantly asking if our standards are working. Are they providing sites what they need to be successful and providing the best services for families? Our direct service staff is crucial, and we recognize the need for strong staff support. HFA sites are structured so that supervisors have time to meet for individual supervision with each home visitor. HFA requires the staff ratio to be 1 supervisor to 6 home visitors, allowing for that unique individual time and planning for that supervision. Across the HFA network, we see large teams with multiple supervisors, and we see small teams with a supervisor who may also be responsible for managing the day-to-day operations of the site, which is considered the role of the program manager. So you may see small teams with that dual supervisor program manager role. Staff receive comprehensive and continual training specific to their role to understand key components of family assessment, home visiting, and supervision. We have a training plan that allows you to provide your team and all staff a training of not only orientation, core training by an HFA certified trainer, as well as HFA wraparound trainings and ongoing professional development. Continuous quality improvement activities are embedded throughout the best practice standards. We hope that your site is just as excited about the data as we are. We want to ensure that you are doing what you are doing is working. And if it's not, let's find ways to improve. This leads us all to accreditation. Accreditation allows us to ensure quality home visiting services are being provided and implemented with fidelity to the model. The cycle of accreditation for sites is every 4 years. HFA is rigorous about the outcomes. Within the best practice standards, there are 154 standards, translating the research of what we have learned about families into practical guidelines for sites on the ground to implement. There have been more than 225 different studies conducted on Healthy Families America home visiting model, 19 publications of randomized control trials. And throughout these studies, we can definitely say it's working. It's preventing child abuse. In a study looking at outcomes up to the age of 7, school-aged children of young first-time moms who enrolled in HFA early in pregnancy were 49% less likely to experience a substantiated Child Protective Services report. In that same study, we also found that HFA prevents the reoccurrence of child maltreatment by 1/3 amongst families with prior CPS involvement. HFA shows impacts in all 8 domains examined by the Home Visiting Evidence of Effectiveness HOMV review for the McVie program. The research also tells us that we see improvements in maternal health, improvements in child health, a reduction in family violence, and an improvement in family economic self-sufficiency.
Healthy Families Georgia is only 1 year away from celebrating the same incredible 30-year milestone as Healthy Families America. Georgia was amongst the first states to implement Healthy Family Services in 1993. The Healthy Families America model is one of the evidence-based home visitation programs used in Georgia. We currently have 9 programs serving 26 counties. This past year, we added 2 new programs to our network, which are indicated in red, and those are Habersham County and Haw County. The Healthy Families Georgia network provided over 12,000 home visits and served 868 families this past year. We currently have 63 family support professionals in our Georgia network, and our workforce continues to grow. As we review the Georgia map together, I invite you to indicate where you are located on the map by using the annotate feature. And so if you would, just take this moment. You can go to at the top of and select the view option at the top of your Zoom window, and then choose the annotate. Thank you, Marcia. I see you're there. And if you do not have access to this feature, feel free to add it in the chat. We would love to know where you're located. This is so exciting. I just love the ability to see where everyone is located.
I'm excited to see some down in the southern part of the state with me. Let's see, Thomas, Brooks, Colquitt. I like that.
It looks like we've got a good response. To me, it's just really nice to be able to see where everyone is located, but also looking when we're thinking about prevention strategies, is really coming together as a group and thinking about how we can bring forth more prevention strategies in communities, especially with the ones that may not have any type of home visitation program in their community or something that they're wanting to expand services. So thank you again. Thank you for participating in this activity. This is great. Diana provided a wonderful overview of the essential components of the Healthy Families America model. We just want to share our insight to help you lay the groundwork for deciding the direction you want to pursue, to identify details to help you compose a solid grant application to launch or to expand Healthy Families services in your community. So let's get started. I'm going to pass it to Caroline.
Thanks.
Go ahead, Annie.
Okay, so as Paige mentioned, we're going to touch on some different areas that you would want to consider if you're hoping to bring healthy families to your community, or perhaps you already have healthy families or another home visiting model and you're looking to expand that model or add an additional model for your community. So the first area that we want to look at is the needs assessment. This is the starting point for either category that you fall into. You're looking to start a new program or perhaps expand with a new funding stream into additional areas, or just serving additional families within your service area that you already have. With the needs assessment, you're really going to be looking at obviously the overall needs of your particular service area. And you really want to begin by looking at the community needs and the needs of the families who reside in your community. The first part that you would want to do in that effort would be to take a look at your service area, identify what your exact service area is going to be. What is the primary area that you plan to serve? Is it a particular county or 2 counties? You know, sometimes you might have a primary area, which is 1 county, and a secondary area, which would be those other counties, surrounding counties that you serve as well. So if you're considering your service area, think about, is it just 1 primary area that you want to focus on, or an extended area that perhaps has similar demographics or shared workforce or shared community resources? Those are all things to consider. And then once you determine what your service area is going to be, you want to be able to provide a basic description of that service area. So you want to be able to talk about, where is it positioned in the state? What's the population? Is it a rural or urban area? Just those general details about the area that you're planning to serve. Once you've identified your service area, you want to be able to take a look around that service area and identify who are the community stakeholders or partners within that service area. So ask yourself, who are the other folks in the community who can speak to the needs within the community? Or who can provide some wide-ranging insight into the community's strengths and challenges? And you want to look at that with a wide lens. So some of the immediate thoughts might be, well, I want to look at, you know, the medical providers or the folks in the mental health field, or the folks in the child welfare field. But I would encourage you to also think about others who touch the lives of families in your community. So think about speaking with stakeholders from the faith community, from law enforcement or the judicial community. Think about local businesses as well. All of those people, and the more of those people you speak with, you're going to have a much more comprehensive view of what those needs are within your community and the types of things that that families are asking for, the types of support that they're asking for in the community. So once you've identified those folks, you definitely want to reach out to them and form that connection and get their feedback about what are they most often seeing amongst the families with which they frequently interact in the community. You may see particular needs coming from the agency that you're already, or group that you're already a part of, but a different stakeholder coming from a different point of view might see additional needs that we haven't thought of. Also, when you're reaching out to your community stakeholders and partners, you want to look for whether there might be underserved populations experiencing those needs, or populations that experience particular needs more acutely. So those are questions that you can be asking those stakeholders when you're reaching out to them. And then you also want to, once you have reached out to all of those partners, you want to look for feedback that indicates a community need that your home visiting services could address. So you've talked to the community partners and stakeholders. You've gathered feedback about what they see as the particular strengths and challenges families are experiencing in the community. You want to look for any common themes that would point towards something that your home visiting services could help address in the community. So some examples of that might be, community partners talking about insufficient community resources being available to meet the needs of families. It could be that they point toward families having difficulty accessing resources that are already available in the community. I've also heard feedback, of lack of or limited access to prenatal care or routine medical care in the community. All of those could be little avenues for you to begin thinking about how your home visiting services could begin to address those needs in the community through the services that you provide. So once you have thought about your community and your family needs, you want to take a look at community data that's available to, relevant community data that's available to provide further insight into what those needs are in the community. And if you see on the slide, you'll see some examples of some resources for some relevant state or local community data. Excuse me. You want to pay attention when you're looking at these data sources to look for things that align with the feedback that you receive from your community partners. So if you heard from your community partners, for example, that let's say you spoke with the child welfare professionals in your community and they really talked about a high number of substantiated cases of child abuse and neglect, you would want to go to one of these sources, and the one that jumps out to me would be Kids Count, and you would be wanting to look up, what are the rates of substantiated cases in my proposed service area? So you're coupling the feedback that you receive from your outreach to community partners with that data to build the case for the need of these services in your community. Once you've done that, you're really in a good position to begin thinking about what is my target population going to be for the services that I want to provide in my service area. We're never all going to have the funding that we need to serve all expectant parents or all parents of children ages 0 to 5 in our communities. So you want to take kind of a deeper dive when you're thinking about your target population. You want to determine what would be the very best use of the resources that you have. Is there a segment of those families that you could effectively serve with the resources you have available? Also, you want to think about, who did your community stakeholders and partners view as the most vulnerable populations within your community? You want to be prepared to kind of drill down to determine those who would most benefit from your services. It could be also that the data you reviewed points to needs within a specific population within your community, and that would be something to consider as well. So just kind of give you an example of how that process works, of really determining your target population. In Dalton, at our site, we started in 1993, and I think our target population way back then was just expectant parents, first-time parents, and parents of young children, again, first-time parents, residing in Whitfield and Murray counties, which, is still our general target population. But over time, we've really had to think about, out of all those families, who can we really effectively serve with the resources that we have? And sometimes it is a particular funding stream that kind of points you in a specific direction. So we have multiple funding streams at our site. And for example, with one of our funding streams, we've been able to narrow the target population that we will serve with that funding stream down to prioritizing single mothers within that overall target population, as well as Latino single mothers. And the reason that we did that is because the data really pointed toward, and as well as the feedback from our community stakeholders, really pointed toward those two subpopulations being the families who were the most vulnerable in our communities. So that's not to say that we wouldn't serve other types of families, that are expectant parents or parents of young children. So with that particular funding stream, we knew the funding that we had available, and we knew how many families we could serve with that money. And so we had to be very specific with the target population for that funding stream. And that's one of the great things about the Hfa model is it allows you that adaptability to determine what is best for your community. So you may have different funding streams where you're prioritizing different subsets of that overall population. And I think Lori has an example of how she's had to shape her target population over time, again, based on funding streams that she was looking at for expansion. Lori?
Yeah, we want you guys to learn from lessons we've learned. And we did an expansion into a very rural community a few years ago. And I went through this whole process that Caroline's talking about. I met with the community and I especially those partners. This community specifically had a very strong family connection board, and their data showed that more than I think 60% of their moms were not receiving prenatal care or inadequate prenatal care according to the data. So we, like Caroline said, we started out originally, we're just going to serve all, expecting parents. And we got real close down to the bottom. And once the funding piece of that come into our plan, we had to draw back because that pot of money would not let us serve anyone who had any prior defects involvement. If they had substantiated cases or open cases or had worked with defects, those families could not be served. So that made us narrow our target population down to expecting moms with no child protective services history.
Thanks, Lori. Does anyone have any questions at this point regarding the needs assessment process? If not, I think we're ready to move on, Paige, to the next slide. Okay. And feel free, if you think of questions as we go along, even when we moved on to another slide, just drop those in the chat box. We'll be sure to catch them before we're finished. Once you've completed your needs assessment process, you've begun identifying your target population, you're really in a good position at that time to take a look at what are your potential points of entry? What is your intake process going to look like? Where are these families going to come from? And really establishing a solid plan for accessing your target population, we think is the key for success for any home visiting program. It's really where everything happens. The goal is to really work toward establishing relationships with community partners that will facilitate a more systematic connection with your target population. So we're looking for something that is going to allow us comprehensive access, hopefully, to our target population, rather than something that's just kind of here and there or hit and miss. And again, as I mentioned before, that's the beauty of HFA is that the model will really adapt to what your community needs. And it allows you the flexibility to establish the points of entry that are really necessary for reaching those families that you want to serve in your community. So the first thing that you want to think about is who serves the children 0 to 5 in your community. Who's already out there serving portions of this population? So again, think back to your community stakeholders and your partners. Who's already serving young children within that group? It might be the local child care providers. It might be local medical providers. It could be school systems, or it could be defects. There's lots of different options to think about. Lots of people out there touching the lives of families with young children. Once you've kind of identified who are some of those groups who already have access to those families, you want to start thinking about who are your potential referral sources within your community. Who could possibly become a consistent source of referrals for your program? Now, ideally, I know that we all think about, establishing some formal agreements with with those potential referral sources. But just be aware that those formal agreements take time to develop. So I think most of us can think back to the beginning or the early days of our home visiting programs, and we had an eye on the longer term goal of establishing some of those formal agreements with some potential referral sources. But at the same time, we were having to look for ways to go ahead and begin generating referrals for our program. So in our case in Dalton, we started, we were one of the first sites in 1993, and we began right off the bat trying to establish a formal referral agreement with our local birthing hospital. And we have one local birthing hospital that serves our 2-county area. So it seemed like, a great option for us that would really provide us some consistent access to the population within our community. Well, it didn't take us long to see that that was going to be like a long, drawn out legal process, working with the legal department at our local hospital. So we did begin that at that time. However, it took about 3 to 4 years to finalize that formal agreement with our local hospital. So in the meantime, we already had funding to begin serving families and needed to be doing that. So we looked for what are those other options within our community to get the word out about our services and to start drawing in families. So again, thinking about who already has access to those families in the community, we started to going to local community fairs or, other programs that some of the other folks in the community were putting forth. So when the local child care centers had special activities for their families, we would show up with a booth, with information about our services. When there was some type of health fair in the community, you would be sure to see our booth there. We would post flyers in local clinics. Again, this was 1993, so there was no social media or any way, like that to get the word out. So I'm talking about all those old school type measures, which again, you would just translate into some of the newer means for reaching out and connecting with people today. But at the same time that you're working on those formal agreements, you want to start, looking for ways just to get the word out to families that you're hoping to serve. So there's lots of different things that you could consider and could try. And I think that Lori might have an example to share from her experience in Brunswick, where their setup is a little bit different than ours in Dalton.
Well, as it relates to expansion or adding a community, Caroline's right. Sometimes you have to get creative. The very rural community that I spoke of earlier, they didn't have a birthing hospital. It was a very small community. And what we come to find out as we're getting to this part is a lot of those families were birthing in 5 or 6 different counties. So it was not that simple to even look for that formal hospital to do an MOU with. So like Caroline said, we need to get real creative and partner with the school systems and partner with the Head Start and partner with your local childcare. So, these are those things that they kind of always relate back to that beginning, but these referrals and where they come from are so important. I want you to learn from my mistake. Do that as early as you can. Make those connections and have a solid foundation of where those referrals are going to come from.
Thanks, Lori. So you've heard a couple of different examples of how this can look completely different in different communities. I think the main takeaway that we would want you to have is just don't be afraid to be creative in reaching out to families in your community. There's lots of different ways to make that happen. At the same time, don't put off forming those partnerships that are going to lead to some of those more formal agreements in the future, because those really pay off in the end. If you are in a community where you're fortunate enough to have someone that you can have a formal agreement with, that's so helpful in the long run to be able to develop a more consistent stream of families being referred to your services. Any questions?
May I ask one, Caroline? I know sometimes, you're writing the grant, you're learning the curriculum, and all of a sudden now you're presented with, you've got to go get these referral sources, right? You've got to make these relationships, these partnerships. Does this curriculum or Healthy Families Georgia, does it give you some branded information that has language that childcare providers, Head Start, that they could understand the benefits to their clients, where it's not written in outcomes that are maltreatment language, but instead in outcomes of early childhood development? What type of tools would be available for somebody using this curriculum?
Yes, the Hfa model does provide information that I think can reach out to different segments in the community to talk about, the ways in which the program would be beneficial to that segment, or to families in general. And I know at the state level, we are always working to create different types of communications that can be used in different ways, depending on who the group is that you're reaching out to. So some of your examples were perfect when you're thinking about reaching out to childcare providers or medical providers or whoever it might be. That's really been one of our goals, is to develop different types of communications that we can distribute to different audiences, so that it gets buy-in from that group of people to see the benefit of, referring families to your program. I think there's always room to continue developing more things for more audiences. But that's one of the great things about the model, as well as our network within Georgia. You have folks that are already working on those things, sharing those things with the whole network. So you have so much laid out for you in advance. It really makes the job of starting a new site, a new program, so much easier because of that. I don't know if Paige or Lori, if you have anything to add to that.
I think Caroline hit on a point, Jennifer, that we try really hard to focus, especially our target, to help them understand the benefits of the Healthy Families model. And the model itself gives us so much of that language that, for example, when we're developing new brochures and flyers that we've done, the language is in the model. It's not as if we're having to come up with that on our own. So it is extremely helpful.
Thank you both. That's wonderful.
And I think too, just to add to what Caroline and Lori is saying, it's so important to think about those relationships with your community partners and just really bringing them in and educating your community about the Healthy Families America model. In addition to that is having advisory board members that also can contribute to that as well.
Any other questions before we move on? Okay, I think I'm going to toss it to you, Lori.
Okay, this next slide is not as much model specific as it is this. We've all serviced written grants and funding proposals several times through the years, and these are things that we just wanted to highlight that you would need to consider before you do that. Most proposals that we submit, they want some agency history. They want to know, how long your agency's been in business, what other services do you offer, how do you support families. They're going to look at things like fiscal management, who's responsible for managing your agency contracts. Do you have the fiscal capacity to manage another grant? And it's going to, they're going to want things like 990s audit. These are things that, you're going to have to be prepared to submit depending on what your funding stream is. And a big part that I want to highlight here is, and then they're going to want to know administrative oversight. Things like, how are you going to ensure you have the right staff or the right quality improvement? How are you going to ensure that you are providing quality services to families and that you are getting the outcomes that you want? And this is where I will really say HFA is very strong. The model is very strong to give you those details about administrative oversight, to explain to you how supervision works and what the goal of supervision is. And it gives you the details that even help you understand how supervision helps you retain staff and how supervision helps your staff stay connected to the families and to the work. We utilize the term parallel process in Healthy Families, and that's really strong in making sure that, baby is attached to mom's, working with the home visitor, and the home visitor is working with the supervisor. And I think it's just really important to understand about Healthy Families. These are not things you have to remember all the time. Once you're in the model and you have those best practice standards, they're there. I can tell you, I don't think I've written a grant in the 10 years I've been here that I didn't pull the standards back out and look for some language around a new question that was asked. Because if you've written grants recently, they want to change them every year. So there's always a new question. So the biggest part of this slide was to just give you some thoughts and start thinking about these are things you're going to have to provide, but that the model will do so much of that language for you. If there's anything else around that page, Diana, Caroline, you think I missed, please feel free to jump in.
I was just going to add, Lori, if you're thinking of bringing services to your community, and maybe you're not part of an agency where you can really speak to a long history of providing services, or maybe you don't have all the infrastructure in place that a funding stream would typically look for when they're considering funding services, don't let that scare you away from pursuing, the idea of bringing services to your community, because there are always opportunities to look to partner with other agencies in your community or government entities sometimes, depending on the funding stream within your community, who have that history or have that infrastructure for fiscal management oversight. And there are ways to partner with other entities who can provide those things and subcontract with you, with your agency, to do the actual work of providing the healthy family services within the community. So there's often a workaround, and I think we don't always see that when we look at a grant application or pursue funding. We think, oh, well, that leaves me out. I don't check off that box. But think outside of those boxes, because a lot of times there are partnerships, potential partnerships available in your community who could fill some of those gaps for you.
That is so true, Caroline. I'm glad you made that point. Does anybody have any questions regarding this side that I may not be able to answer on my own, but someone on the panel can?
I was just going to chime in. You make a really good point, because some that are a nonprofit that might not have a long fiduciary history, you can sometimes partner with the school system where they would be the fiduciary agent, and then you all would provide, your nonprofit could do the actual service provision. And that really helps you get established and gives peace of mind to the funding source. So I'm so glad you brought that up.
And Jennifer, that makes a really good point. Now, I'll add to this. Creatively, one of our sites is partnered with a housing authority, and I think that's awesome. And again, our model allows us that kind of flexibility. These topics here are more around when you're trying to get funding, but as far as HFA model, the creativity is fabulous. So I think that is a great point to make.
Yes.
Go ahead, Paige.
I was just going to agree. And one example that I can share is, even thinking about applying for an application, it goes back to what everyone is saying. Oftentimes you look at those applications and you see that it's only, you have to have certain requirements about a government entity has to apply for the application. And that happened to us in North Georgia. What we did is partnered with the city of Gainesville to be able to bring that grant to the community. And so we really offered the services with Healthy Families in a couple of different components, while they held the contract and was responsible for that physical management of that.
Thank you, Paige. Okay, any other questions? All righty. We wanted to talk to you real specifically about service delivery. Obviously, we're all here because we know it's home visiting, but I want to give you some real specific details about what that means for us. And as Diana said, it is a face-to-face interaction in the home, in person, either virtually or in person. It occurs between the family and the home visitor. The goal of these home visits is to promote a positive parent-child interaction, healthy growth and development, and enhance a family's overall functioning. Typically, these visits last a minimum of an hour, and the child is always present. These visits are designed to be flexible, accessible, developmentally appropriate, and strength-based, so that they are responsive to each individual family's identified needs. During each of these visits, the worker is able to observe and access the current level of parent-child interaction, showing either attachment or a lack thereof, to which then the supervisor and the home visitor can plan activities around or needed education, or review the family's goal plan, or possible need of referrals or more advocacy necessary that each parent can be emotionally present, resulting in successful parenting. More specifically, during these visits, home visitors share curriculum model activities, safety resources, and I just want to reiterate again, they do a lot of observing of parent-child interaction and the child's development to always make sure that those things are on target, and if there's any needs, they can address those needs, or if there's a concern by the parent. Maybe an example of that is you have a new mom with a newborn, and the home visitor is not observing a lot of eye contact with the mom, and mom's not wanting to hold the baby. There could be a lot of factors going on. It could just be stress. It could be just the newness of a new baby, or it could be something more crucial or more dire need of support. Like maybe mom is experiencing some maternal depression. So these are always things that we're looking at during a home visit, and especially in those early days, right when the child is born. We really want to focus on all these activities. Does anybody have any questions specifically as it relates to service delivery or home visits? Anything you guys, Paige, Caroline, think I've left out? Okay. Try the next one.
I forgot to unmute myself. I am so sorry. I was enjoying the presentation. So program monitoring and evaluation for effectiveness. HFA has specific tracking and monitoring requirements. For example, on a monthly basis, you'll be tracking staff caseloads to ensure that staff are not being overburdened by having too many cases on their caseload. On a quarterly basis, we may ask you to look at home visitation rates, again, to ensure that families are receiving the adequate number of home visits that they should based off of those HFA levels of service. Some of the things that we'll ask you to look at annually are determining if children are getting their immunizations on time, and if children are receiving ASQ questionnaires, and if moms are receiving that postpartum screen, pre and postpartum screen. Many HFA programs collect data utilizing a data system, and it helps to track and monitor what data they're collecting. HFA also will provide sites with spreadsheets if they choose to use them. Continuous quality improvement activities give you a closer look at what works and what may need a little change to improve the outcomes. Sites will also have a community advisory board, as mentioned earlier, to serve as a support system, a sounding board, decision makers, and advocates for your program. As mentioned about the community partnerships, these are great individuals to include into this community advisory board. They serve as your advocates, and they are also serving that 0 to 5 population. These key activities are all considered part of the program manager's role and responsibilities, in addition to accreditation process, building relationships with the community partners, and the additional day-to-day responsibilities. But don't worry, you're not alone. HFA provides training and technical assistance. You're connected to a TA as soon as you affiliate with Healthy Families America. Your TA will walk you through the implementation process and is there to support you and your site. They really are accessible and available and are just as passionate about delivering services as you are. HFA has developed an online community where you can go and join other members of the community, post questions, answer questions, and connect with other members within the HFA network. You can access our network resources through our online community. And we also have a community calendar where we post training and meetings and sessions that are happening within our HFA network. There's also great support that comes to you from Georgia Home Visiting Program.
part of the Georgia Home Visitation Program and Technical Assistance and Data Team, Healthy Families programs receive regular technical assistance and training through the state office. Programs are provided model implementation support around program planning, development, implementation, and also support around the Healthy Families America accreditation. Continuous quality improvement strategies are used to optimize practices and to improve the quality of services. Program managers and supervisors also participate in monthly collaboration sessions, which have resulted in very strong relationships. Annual Healthy Families Quality Assurance site visits are conducted, also to support the delivery of high quality home visitation services and to maintain adherence to the model fidelity and programmatic requirements. The Healthy Families program actually has a data system that we utilize in all the Healthy Families programs. Enter data, they collect information data for the families that they are serving. It also serves as a performance monitoring and programmatic reports. Some of the Healthy Families America custom designed Healthy Families reports that have been added to our local data system, and also their support around completing and utilizing the Healthy Families America spreadsheets. There's regular training that we offer through the Georgia Home Visitation, which really pertains to like the performance measures, any kind of screening tools or model specific trainings. Advanced Healthy Family model specific trainings are offered annually. And the training is really brought forth from getting feedback from the entire network, from program managers, supervisors, and the family support specialists that participate in the network, because we really want to make sure that we're supporting all of the workforce, because the work that they do is so important and they are the tool. So we want to make sure that they are getting the support that they need. And I also work as, collaborate with the national office, and we offer, regular or routine joint trainings and to support the Healthy Families American Network. One example of that is currently the new best practice standards have been updated. And so I have joined forces with our Healthy Families America technical assistance and a support trainer at the national office. And her and I work together providing the overview for the Healthy Families programs through one of our work sessions. So this is a real, opportunity not only to support the staff or the workforce, but it's really important is just bringing them together and connecting. So the networking opportunity is also extremely important as well. Just to highlight the Georgia Home Visitation funding sources, we are very thankful for Georgia Department of Public Health, Georgia Division of Family and Children Services for their continued support around providing Healthy Families programs in Georgia. These funding streams are, as you can see, are listed, are from different resources. And each of the program directors had mentioned that, each program is unique and they receive different funding sources. So this is just a list of those. One I want to bring to your attention is there's a new funding source that's coming on the landscape, which is Family First. It's through the Family First Prevention Service Act. And Healthy Families America model has been included in that prevention plan. The last is something that is really important to highlight, as well as other funding sources that Healthy Families programs utilize, and that's through the United Way, local foundations, and also agencies are really dynamic in bringing different types of fundraising events to support the great work they're doing. So anything that you want to add before we move to the next slide?
Paige, I was wondering, it's great. Jennifer and Diana are answering some questions in the chat. And there was a question that was I'm going to say a great question, but we could elaborate on it. One is Wendy Green is wondering, are there specific criteria outlined for staff qualifications? And I know it might be in the Healthy Families model, but like when we think of writing a grant, sometimes we don't have access to the model if it's a new program because you don't get that till you pay for it. So all of a sudden you're writing a budget. Does this person need a 4-year degree? Does the degree need to be in a specific niche? You know, what criteria do they need to be considering as they look at that budget and work on building out a program to present for a proposal? Can you elaborate there?
Yes, primarily if anyone is interested in completing an application, they can reach out to me and I will be happy to share that level of detail where they can ensure that they're thinking through the personnel cost and the expenses when it comes to different job requirements. Primarily with program managers and supervisors, it's a minimum of a bachelor's degree with 3 years of experience. And preferably a master's degree. The same as for clinical supervisors. And then family support specialist, it really depends oftentimes on what the agency's recommendations are, but they are certain criteria that applies there based on education as well as experience. But the unique piece that I really want to highlight with Healthy Families America is they really consider the lived experience. And so that's something we need to take into consideration too. So that's where it would be helpful to kind of think through that with anyone that's interested in starting a Healthy Families program. I'd welcome an opportunity to speak with them.
Thank you.
Our next slide is all about questions. We just want to give you an opportunity to come off mute if you prefer, or to put any kind of questions in the chat. Well, feel free to reach out to me if you do have questions. I welcome those. And as you have experienced today, we have wonderful resources within our network that is willing to share and to provide any kind of support as well. So I would encourage you to contact me, and here is my contact information. Feel free to reach out to me via email or by phone. I'm very thankful that I have Diana to support me in her role as the site development specialist at the Healthy Families America level at the national office, where we can work, we can work closely together to ensure that all questions are answered at the state level as well as the national